Hi everybody, I wanted to do a nursing video on how I personally use my nursing diagnosis handbook. Mine is by Betty J. Ackley and Gail Ladwig, Mosby. It's the 9th edition, Evidence-Based Guide to Planning Care. Okay, so many of you have probably been in clinicals many times. Maybe you're getting ready to go start your clinical rotations in the long-term care facilities or in peds or in mental health or, med-surg, maternities and such. Well, what we do is we go in and you're taught body assessments, head-to-toe assessments. More than likely you're taught that back in the lab, and you have to sign off on certain skills before you're allowed to do them in the clinical setting. Then as you get more into your schooling, they teach you to come up with a nursing diagnosis. Well, a medical diagnosis is something that a provider, someone with a doctorate or such, a higher education level, they make a medical diagnosis based on labs that they order and tests that they order, and reading these results, and also sometimes with collaboration of radiologists or pulmonary, things like that. So I totally said that word wrong. Anyway, those are things that us nurses cannot do. A nurse practitioner can probably order some labs and some diagnostic testing, but an RN or LPN cannot. But what we can do, based on our physical assessment that we have performed on our patient, by going by the subjective data that they have shared with us, how they're feeling, how they describe things, their history, what their family says, and then the objective data, like I said, what were their actual vital signs that I took? What am I seeing them do? How am I seeing them walk and talk? Are they able to take care of themselves, does it look like? Are they underweight, overweight for their height and build? Are they shaking? Is their speech clear and appropriate? Do they seem mentally aware? Can they answer my questions? All these different types of things that you're taught to assess all at the same time. And then we can come up with a nursing diagnosis. We can also come up with our nursing diagnosis kind of based on the medical one. So I'm not quite sure how to start with this book. This book, when I first got it, it was really intimidating. I just started, going through it, and I'm like, how do you use this? What is this stuff? So for instance, let's say with the medical diagnosis of pneumonia that the doctors come up with based on, their ABGs, their CBCs, the labs that are drawn. They probably had a chest x-ray, things like that, to see if there's fluid in the lungs. He can come up with the diagnosis of pneumonia. I'm not allowed to do that, but what I can do is I know that they're unable to breathe well, so they can have a nursing diagnosis back here. These are all of the nursing diagnoses so far that are approved for use. Some are hard fact and some are risk for. They're at risk for something, and then some are positive. If you're seeing something, if there's a mother breastfeeding well, has effective breastfeeding. So it goes both ways. So like I said, with pneumonia, I could say something like, okay, so these words are bolded. So this was really hard, and in the very beginning, I would read every single one of these, and then it gives you the page number. You can go to that page number, which we'll do in a minute, and it describes what this means. Maybe some signs and symptoms you see in your patient, and that will help you decide if this is an appropriate nursing diagnosis for your patient based on your assessment and data collection. So again, pneumonia. I could say, well, activity intolerance. Sure, they're not able to breathe well. They're probably going to be shortness of breath upon any type of activity. So I might write that down with the page number off to the side. I could say ineffective airway clearance. They have fluid in their lungs. They're not going to be able to breathe well. They're going to have their airway is not going to be as patent, meaning as clear. I could go down here to breathing. What does it say under breathing? Oh, ineffective breathing pattern. Well, I'll write that down too, and we'll check that out. Let me see. With pneumonia, we're talking about oxygen and CO2 imbalances. So here's gas and impaired gas exchange. You know, and there's so many more that you could go off of that. But let's take a look at a couple of them, and I'll show you how to use this book. So let's go from here. So let's look at which one do I want to look at? Let's do the breathing, ineffective breathing pattern, page 192. So I'm going to go to page 192, and what I'm going to see, this one starts at the very bottom. It's going to have ineffective breathing pattern. It has the person who came up with this nursing diagnosis and the definition, and it says inspiration and or expiration that does not provide adequate ventilation. Then we keep going, and it's going to have defining characteristics. So these are things that you might see in your patient. So these are the things that you can read to say, yeah, that fits my patient perfect, or no, what I want you to know is it doesn't have to be every single one of them. It could be one or two, it could be most of them, it could be all of them. But some things we might see with ineffective breathing patterns is alterations in the depth of their breathing, altered chest excursion, assumption of 3-point position, bradypnea, decreased expiratory pressure, decreased inspiratory, decreased minute ventilation, let me see, dyspnea, nasal flaring, orthopnea. They could have a prolonged expiration phase, pursed lip breathing, big with COPD patients and emphysema patients, tachypnea. Okay, so, or use of accessory muscles. So instead of, you're seeing not only their chest, they're using their abdomen, they're using their rib cage, you're using everything for breathing because they're having a very hard time. So these problems could be related to anxiety, the way their body's positioned. They could have a chest wall deformity, fatigue, hyperventilation or hypoventilation syndrome, neurological immaturity, obesity, pain, perception impairment, respiratory muscle fatigue. There's so many different things that for reasons for they could have these up here. Client outcomes. What do we want to happen? Okay. And then these are nursing interventions and rationales. If it has a dot in front of it, it's independent. A triangle means collaborative. You're going to be working with other people, evidence-based nursing, so forth. So we're going to monitor their respiratory rate, depth, and the ease of how they're breathing. And then it tells you the normal respiratory rate is 14 to 16 breaths a minute in the adult. Note the pattern of the respiration, the anxiety level. If you can't breathe, you're getting a little anxious. Okay, that's a scary, scary thing. And so on and so forth. There's so many things that we are going to monitor. Okay, so that's one. So yeah, we could probably use that. What's another one? Impaired gas exchange. So let's look at that one, 402. Ooh, it's getting hot in here. I shouldn't have. Let me turn my heat down. I'm down in the basement. It was freezing down here when I first came down. Let me bacon myself now. Okay. So the definition, let me see if I can zoom in instead of holding the book up. Whoops, wrong way. Okay, so the definition is excess or deficit in oxygenation and or carbon dioxide elimination at the alveolar capillary membrane. Okay, so at the very, very base where your alveoli are, you know, your CO2 is supposed to be exchanged with fresh O2. Well, there's an impaired exchange there, so that's why we're having difficulty breathing. So defining characteristics could be, you might see abnormal arterial blood gases or ABGs. When they come and take their ABGs, the levels might be off. Well, they will be off. Abnormal arterial pH, abnormal breathing, such as the rate, rhythm, and their depth of their breathing. Is it shallow? If they're not able to get in enough air, they're not going to be able to take a deep breath. So it's going to be very short, shallow breaths. Their skin color, it's probably going to be pale and dusky because they can't get fresh O2 there. Okay? They might become confused. You might see signs of cyanosis, decreased carbon dioxide, diaphoresis. They might start sweating now. Dyspnea, difficulty breathing, a headache upon getting up, hypoxia, there's all these things. So like I said, you can see I used this here once. I have like 4 things underlined, so I was able to use this diagnosis at one time. So, related to ventilation, perfusion imbalance, alveolar capillary membrane changes. Okay, so then it goes down to the client will over time demonstrate improved ventilation, adequate oxygenation, and if they say, well, what can you do as a nurse? What's a nursing intervention? What can you do to help with this? Well, again, we're going to, where'd I go? Sorry. We can monitor their respiratory rate, depth, and ease of respirations. We're going to be taking their vitals. Well, it depends on how bad they are. It could be every 15 minutes, could be every half an hour, could be once a shift, or once every 4 hours. We're going to auscultate their breath sounds every 1 to 2 hours, anteriorly and posteriorly. We're going to listen. Are we hearing adventition breath sounds? Are we hearing crackles, rails, gurgling, wheezing? Okay, all those things could mean obstruction. See, it just goes on and on and on. We're going to monitor their level of consciousness. We're going to reposition the client in a high semi-Fowler, meaning sitting high up in the bed. We could do that. We can have them lean forward. You'll learn about the tripod position. They're, like sitting on the side of the bed, and they have that table in front of them, and they're leaning on their elbows, so they're, it's hard to explain. I'd have to show you. But they're, it's just, you'll have to look it up. It's a position where they can get the most lung expansion, help them get in as much air as possible. We're going to observe the skin for cyanosis, okay, especially their tongue, the oral mucus around their mouth. You're looking at their nail beds. Do they have capillary refill? Things like that. Now, another way to use this book, which I did not know my first 2 semesters, it would have been nice to know. But then again, I didn't really explore my book either, so that's my problem. Okay, so what, in my book anyway, see some pages are white, well the ones that are in blue are the medical diagnosis. Okay, so let's go to pneumonia, just because that's what I've been talking about. So a doctor can say, you have pneumonia. So they're all in alphabetical order. I look at pneumonia, and all of these are from back here that I showed you that apply to pneumonia. Do you know how many times I went back and forth between, I went down each list, but that's okay. That's how I got to know my book better. But, if you're in a hurry, you have to turn this in the same day as clinical or whatever, know that in this book anyway, it has the medical diagnosis, and then it has all the nursing ones that you can use for it. So, activity intolerance, ineffective airway clearance, impaired gas exchange, ineffective self-health management. They're not going to be able to take care of themselves as well. Hyperthermia, deficit knowledge. They may not know to change positions. They may not know treatments of pneumonia. Imbalanced nutrition. They're not going to want to eat. They're not feeling good. So that's something you've got to think about as well. Impaired oral mucous membrane. They're going to be dry-mouthed, and they're probably going to be trying to breathe, mouth breathers. They are at risk for acute confusion because of an underlying illness. They're at risk for fluid volume deficit, risk for vascular trauma, readiness for enhanced immunization status. So these are all ones that you can use, okay? You have to go back here to find the page number, but they have the same words highlighted as in the back. Okay, so really get to know your book. And like I said, with pneumonia, you can also say something like impaired mobility. They're not going to be able to get up and walk around well. They might, get lightheaded and dizzy. They're going to be risk for fall. That's another one. So on and so forth. So that's how I use my book. Now, this is something I came up with on my own, and this was after being in clinical, actually I made this up after Med-Surg 3. I would always carry around a little notebook, and each hospital has their SBAR paperwork set up different, and I would get confused everywhere I would go because the papers would be different. So I know what expectations were of me for my head-to-toe assessment because I had to sign off on it. I knew what I learned things along the way, like an orthostatic blood pressure. I didn't realize I needed to take a heart rate with each. When you have when you're taking an orthostatic blood pressure, orthostatic blood pressure, it's usually taken 3 times a day, and you take it in 3 different ways each time. So the first time they're going to be lying down. I start with lying down if they're already in the bed. You're taking their blood pressure, and then you're also recording the heart rate at that time. Then you're going to sit them up in the bed. Like, I usually have their legs over the edge of the bed. I have them sitting there. I give them a few minutes, and then I take another blood pressure, and I also record their heart rate. And then you do it again once they're standing. Now know that a lot of patients like this, they're weak, and just that little bit of movement takes a lot out of them, so you might want to have some help. Call in a classmate, call in your instructor, whatever. But that's just an example. But this is what I came up with, what works best for me. So up top I made allergies and I highlighted it. I have their gender, I can just circle male or female, the date of birth, their age, their medical diagnosis, today's date, and the date of admission. Nowhere do I put their name or their room number. Okay? Because if I lose this piece of paper, that's HIPAA violation. Someone could pick it up and know who I'm talking about, okay? So 7:30 vitals. This is what I'm doing first thing in the morning after I get report. I stay in my patient's room, and first thing, even before I do this, I'm doing a visual. I am looking at their IVs, their IV site. Am I seeing problems with their IV site? Sense of infiltration, redness, swelling, heat, things like that. Cool skin, that's infiltration. The catheters come out and the fluid is going into their excess tissues and not into the vein anymore. Am I seeing phlebitis, which is redness, hard, swollen vein, it's painful to the touch, things like that. Is their IV running? Is it dripping? Is it, when I got report, they've told me what the IV's running at and in what arm or extremity. Is it in the proper place, and is it running at the right rate? If they're on oxygen, is their oxygen on? Hint, hint. It might be in their nose, but don't assume it's on, and don't assume it's on the right amount. So I'm checking all of this. I'm talking to my patient, chit-chatting for a moment, waking them up if they're sleeping, being very, nice. I'm not a morning person, so I don't want to be bamboozled with things going around my arm right away. So I'm just kind of slowly waking them up while I'm checking these things. If they have, dressings, if they have a wound or something, I'm kind of looking at that really quick. Then I go and get my stuff and I come back and I do their vitals. So I'm looking at their temperature, and did I take it orally on their forehead, or was it rectal? I've only had, actually, I've never done that, but I just put that on there. Heart rate. Did I take it on their left or their right radial? My left and right's backwards because I'm thinking anatomically, I'm sorry. Their respiratory rate, what was it? Their blood pressure, and did I take it in the left upper arm or the right upper arm? Did I take it manually myself, or did I use the Dynamap? The automatic, you press the button. What's their O2 stat? Saturation, and left or right? What finger did I take it on what hand? What's their pain on a scale of 0 to 10? Location of the pain, type of pain, have them describe this. And I recently had a patient's friend kind of go off on me. She's like, oh my God, just give her pain. Why are you always asking all these questions? And I said, it might seem monotonous. And I said, but there's different types of pain, and it tells us different things, and it tells us if she's getting better or worse or what's expected. There's expected pain as well, but I only know if she's getting better or worse or stabilized if by her telling me, okay? And I said, so there really is a reason for my mat. And after that, she didn't give me a hard time at all. She goes, oh, okay. I said sharp pain's different than dull pain. If you have someone complaining of chest pain and you ask them to take a deep breath, and they said they feel a sharp pain, that's not a heart attack, that's a PE, you know? So, I mean, well, it could be a multitude of things, but I would lean more towards respiratory distress than I would cardiac, okay? So there's different types of pain, different things. Then my 12 o'clock vitals. I have it right over here. And then, let me see if I can zoom in. Here's blood sugars. So if I have a patient, I have to take their blood sugars. Here's the one before breakfast, before lunch, before dinner, and what type of diet are they on, whether they have blood sugars or not. Are they on a full liquid diet, a soft diet, a cardiac diet, a diabetic diet? What kind of diet are they on? Here's a place for orthostatic blood pressures. I circle yes or no if they're on it. And then, like I said, I do them 3 times a day. So the first one's here. They are laying down, the blood pressure. Here's a place for the heart rate. Then I do it sitting, the blood pressure and the heart rate. And then I do it standing, blood pressure and heart rate. What I have under here. Okay, so now, what's their level of consciousness? Perla, speech, hearing. Do they have an aid in their ear? Sorry, I'm moving fast. What was their gait like if they're walking? Is it slow and steady? Is it choppy, side to side, wavering, weak? Do they need assistance with ambulation? And are they using like a walker or a cane or something like that? I'm going to put this down because it's really hard for me to read and try and show you. I'll just kind of point. Their strength in all 4 extremities. Is it strong and equal bilaterally? Is it not? You know, I'm writing all this down. Their range of motion. Are they able to put their hands up over their head? And, you know, do they have good range of motion? And I do like ×2 or ×4 extremities. I write that down off to the side as well. Their lung sounds. Their mucous membranes. Are they wearing dentures? Their breath sounds. Is there sputum? Are they coughing? Is it a wet cough? Is it a productive cough? It is a dry hacking cough. All that means something different as well. Am I hearing any heart sound? Their pulses. Am I feeling pulses, peripheral pulses, radial pulses, PDO pulses? Sometimes with people with lower extremity edema, you might not feel a PDO pulse. So I write down if they're strong and equal bilaterally, if they're weak on one side, if I'm having trouble palpating their lower extremity, and if I am having trouble palpating a pulse anywhere, I get my instructor and the staff nurse and just have them double check me. That's only happened one time and I was right. So then I go to bowel sounds. You're going to listen before you palpate their abdomen, because when you start palpating and touching their abdomen, you can create bowel sounds. So first thing we want to do is we want to listen. I ask them, when was the last time they had a BM? BM is bowel movement. And form, was it diarrhea? Was it soft? Was it hard? Was it formed? What? Because that tells us a lot as well. I know it sounds silly. Do they have a Foley in place? When was it put in? Their abdomen. Did I feel any masses or anything? Tenderness, yes or no? If so, where? I'm checking their capillary refill, their skin sugar, their skin assessments. Am I seeing any moles, scarring? I even write down if they have tattoos and where they are. That's just me. Am I seeing any visual masses, bruising, redness, rashes, etc.? Bruising locations, if so, where? Scarring locations, if so, where? Skin, miscellaneous, you know, I just give myself some room to write. Do they have a telemetry in place? Do they have supporting oxygen running? What type is it? Is it nasal cannula, mask, what? And what's the rate of the oxygen? Their IV, do they have one? Where is it? What gauge is a needle? What type and what's it running at? How fast is it running? Is a bag properly labeled? I check this too in my initial assessment before I even do the vitals. I'm looking, how old is that bag? You know, did someone label it properly? And the tubing. Date hung, when does it expire? And then the tubing, is it properly labeled, date hung and expired? If not, I'm changing the tubing. Okay, I don't know and I'm not going to take anybody's word for it. This is my patient. Let me see. Medications. Oh, piggyback. Do they have a piggyback? If so, what is it? What's the rate? When was it hung and when does it expire? Breakfast. What's the percentage eaten and how many total mLs did they drink? They're different. Solid is different than fluid. This is for I's and O's. In med-surg, every patient I had to take care of their ins and their outs, their input and output. So I was detriment on this. So this was breakfast. Lunch, again, how much, and because most facilities they ate 25%, 50%, 75%, 100%. And then how many mLs, and everything is written down usually, a small glass of orange juice or a cup of coffee, all that's usually written down in ml. Well, it is written down in mLs. So you can't say he had 4 fluid ounces. Well, then you do the conversions because they want to know mLs. And dinner, same thing. Then I have like RT, so respiratory therapy. Do they have it? If so, what time? Because then I can document my care, maybe ambulate my patient around this time, or maybe I know if PT is coming in, I work around them as well. Speech. Do they have speech therapy? And it's not just for talking. Swallow studies have to be done by a speech therapist. OT, do they have that? And then, this is very important for input and output, intake and output. So their daily urine, their time, how many mLs, the color, was there sediment, was it clear, was it dark, did it have blood in it, was there any foul odor, and was there any sediment? So I do all that for total mLs for the end of my shift because I have to document all of that. So if they're able to use the bathroom, I explain the importance of this, and so I have a hat in the toilet and I tell them just to go and let me know. This is if they can get up and walk on their own. Let me know, I'll measure it and take care of it. Some people are embarrassed by that, but I tell them, it's not a big thing, it's part of my job and I really don't mind. And then same thing, bowel movements, type, time, amount, color, formation, and then I write that down as well. On the back, I have a place for shift report. So as the nurse is going through things, her head to toe, what she's noticed during the night and all that, I'm kind of writing it down really rough here. Sometimes I have it going down the side. And then when I have time, I check out their labs in their chart and in the computer. I look at both. So I write down the lab, I write down that hospital's value, what they consider normal, because each facility is a little bit different because of their calibrations down in the lab. I write down the abnormal value, whether it was high or low. I write an up arrow or a down arrow and what it was. So I write whether it was high and what it actually was, and then I try and figure out, and this gets easier as you get to know your labs, what's the reasoning for it? Could it be dehydration, or is it what causes, whether it's high and low, and what could happen? Because there's certain things I need to watch out for. I give myself a lot of space because a lot of my med-surg patients have a lot of abnormal lab values. Diagnostic testing order, like do they have a CAT scan, a chest x-ray, an ultrasound, what? So I put the test, the date, the time, and the result once it's read. And then I have a place for their meds. The medication, the dosage, the route, the time. Their patient history. I go through patient's histories tells you a lot, not only about what they're particularly in for on that day, but their history can have a lot to do with that, or I need to watch out for certain things that maybe they're not experiencing yet, but I know they have a history of it, whether it's cardiac problems, respiratory problems, emotional anxiety, psychosis, depression, pain, chronic pain, whatever. History, family history is very important. It's also important to know your patient, like, do they have a way to, what are their transportation issues? What are their support issues at home? Do they have someone that's able to be with them? If not, I need to make some arrangements for them once they call home, and there's people in the hospital to do that, but I need to know as their nurse, and I know that by talking to them and by reading. Not everybody tells you things. They think it's private, they're embarrassed, whatever. There's people seeking out lots of things too, so you have to kind of be careful of that. So this is personally what I made up. I like it. A few of my classmates have borrowed it. I don't mind because I'm all about the love. You know, make it your own. I'm not saying this is bulletproof, perfect. I'm saying this is what I assess for. These are things I look for. And by having copies of it, you know, my allergies are highlighted. It's up top because you go in, you talk to your patient, you introduce yourself, you're asking to look at their armband, you ask them to give them their name, date of birth, and ask them if they have any allergies. If they forget or you know, I have it. Or sometimes it's not in the chart, but they tell me I have a sea fish allergy. Well, that's important to know, especially if they're having something done with iodine later, you know, a cath put in, or, you know, some kind of diagnostic test that uses that. So it's very important to know all this. And it's a lot to get used to, but after a while, having it written down and going in the same order, it becomes routine. And then you don't necessarily need to look at this all the time. You do get faster and you do get better. And practice on your friends, practice on your significant other, practice on your kids, because we have them and we can make them do whatever we want to. Trust me, they're going to get tired of you. But at the same time, they like to play with my pulse ox thing. Like, I bought my own pulse ox because one med surge unit I was on, I could never find. There was only like 2 to the whole floor. And it was a big floor. And I was like, okay, this is ridiculous. So I ordered my own and keep it in my pocket. And it is, it did give me the same results as the one in the hospital. I did double check and make sure that we were, you know, within the same range and such. At one time it was just like 1% off, but it was like, I got it at Walgreens or Rite Aid, and it was about $50. And it's very, very worth it. And that's just small enough for me to keep in my pocket. It does come with a lanyard. You can keep it around your neck. I don't like that. It can get caught if I'm, you know, lifting a patient or whatever. So I just keep it in my pocket. But I hope this helps. Rate, comment, subscribe. Let me know if you have any questions. Hopefully I've helped you with these nursing diagnoses. They are difficult in the beginning, but I promise you, having to do them over and over and over again, you get a little faster and you get a little better, and it's just going to help you become a better nurse in the long run. So practice them, get to know your book really well, look through it inside and out, and don't be afraid to ask an instructor how to use the book. They're the ones telling you to get the particular book. You know, I'm sure they would be more than happy to help you out. And I do like this one. I haven't seen any others, to be honest, but this is one I'm comfortable with. So if you like it, you know, you might want to look it up. So anyway, thank you so much to all my old and new subscribers. I do this for you guys, and I hope everyone's semester is doing well. We have about 8 more weeks until we're done, or 9 more weeks until we're done. And wait, no. Yeah. Oh, time's flying by so fast. I don't know. We're almost done with our first 8 weeks. Like in a week and a half, we'll have our finals, and then we move on to our second 8 weeks. So that'll be Med-Surg 4 for me. So anyway, I hope you all have a fabulous day, and I'll talk to you later. Bye.